This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. You may have seen this paper trending called Migraine-Related Stigma and its relationship to disability, interictal burden, and quality of life, which is recently published in Neurology. With me to discuss is the lead author, Evan Shapiro, professor of neurology at the University of Vermont. Dr. Shapiro is well known to our society as a headache specialist, as well as a fierce advocate for patients living with headache. Bob, thank you so much for being on our podcast.
Thanks so much for having me, Tesha. It's great to be here.
You've done so much work in the field that I'm surprised we haven't had, at least I haven't been able to interview you from before. So why don't you tell us a little bit about the study that was published in Neurology and why you decided to investigate migraine-related stigma?
Over the last really 5 to 10 years, there have been a handful of studies which have indicated that the attitudes that people have towards migraine or people who have migraine, and the attitudes which people who have migraine have towards either the disease or the fact that they experience it, have a big influence on quality of life that people have who are experiencing the disease. And this study was intended to serve a couple of important functions. One is to come up with a metric, a tool, to be able to quantify the magnitude of the stigmatizing attitudes, and also to see what their impacts might be with respect to other patient-reported outcome measures, such as disability, interictal burden, meaning the degree to which migraine impacts people between attacks of headache and other symptoms, and also migraine quality of life. And fortunately, we have this large study which has been funded by Lilly for the last 5 years or so, called Overcome. And Overcome is distinguished really by being the largest population-based survey study that's ever been undertaken to examine people who experience migraine. So it was a survey study that was through the internet, and it was a large panel of questions that were asked of the respondents. And the respondents were recruited to ensure that they were a representative sample based upon sociodemographics of the U.S. at the time that the sample was collected, which was 2018 through 2020. And consequently, it was possible to recruit over 59,000 people who met the ICHD diagnostic criteria, the accepted diagnostic criteria for migraine, and who had had an active set of symptoms during the past year. So they either had a severe headache or they had an actual migraine attack in the past year. So people who met the diagnostic criteria and actually had active migraine. And the questions that we posed to them were a whole host of questions about sociodemographics and comorbidities and a variety of things, but there were 12 novel questions that were asked specifically of this group, which were looking at attitudes towards migraine. And these questions were arrived at by initially a set of focus groups of people who had migraine to see what they thought was of interest and importance. And then it was refined by expert opinion about which questions would be the right pared down number of questions. And all of the questions in this group of questions, which are now called the migraine-related stigma questions or MIRS, M-I-R-S questions, all of them kind of begin with the stem. How often have you felt that others believe that you were using migraine to obtain some advantage that you didn't deserve? Or how often have you felt that others believed that migraine was not taken seriously? These are the sorts of questions that were asked. And using a statistical method called exploratory factor analysis, it was possible to group the questions into really two very distinct themes. And we call these two themes secondary gain and minimizing burden. So secondary gain is where people felt that others believed that they were using migraine to an advantage which was unfair, either to avoid obligations or to obtain things like drugs, which they didn't deserve. And then the second set of questions kind of coalesced around the idea that migraine itself wasn't really a worthy disease or type of disorder which should warrant attention. These were sorts of questions that an example would be, that people who have migraine really bring it on themselves, or they don't really need to see a doctor, that sort of thing. So the first, meaning the secondary gain, was really stigma towards people who have migraine, whereas the minimizing burden was essentially a type of stigma towards the disease itself. So these questions are really a reflection of how people who have migraine perceive others' attitudes towards migraine. So those other people's attitudes towards migraine is what we call external stigma, and the attitudes of people who have migraine are called internal stigma. So this was really a perception by people who have migraine about what their environment is, the external stigma environment is. And the advantage of this is that we were able to quantify the magnitude of the responses to these questions such that their answers were able to be binned into never, rarely, seldom, often, or very often experiencing these attitudes. And this had the advantage that we are now able to ask when people who have migraine often or very often experience one or both of these types of stigma, either secondary gain or minimizing burden, how that might impact these other types of patient-reported outcomes that are often used, either to look at disability or interictal burden or migraine-specific quality of life.
And so before we get into the findings, it sounds like, first of all, you had a real large data set and a really nice survey with, a lot of thought put into it. Why don't you tell us about the demographics of those that responded, as well as about their migraine burden?
So the population was really a representative population of people who have migraine. So it's unsurprising that it was 3/4 women. In terms of the racial and ethnic backgrounds, it also was representative in terms of the percent that were either white or African American or Hispanic, etc. So the average age was 41.3 years. So this really was a representative sample of adults in the United States who have migraine. And it's actually pretty close to the demographics of the clinical trial populations that we typically see in clinical trial work. So the responses of this group are really quite informative given the very, very large size of the sample. And the size of the sample is so large, in fact, that almost every comparator that you could make would have statistical significance versus any other comparator. When the magnitude of the sample gets so large, just asking whether or not there's a statistical difference between two different comparators is not necessarily telling you that it's clinically important. So we look at other statistical methods to ensure that the effect size and the magnitude was really clinically of interest. In this study specifically, there was nothing subtle about the results, and they were very dramatic, and I think really tell us quite a lot about the setting in which people with migraine are living.
Well, why don't you tell us a little bit just about the frequency so we can see how this correlates with patients that we see every day in clinic?
The frequency of headache days, which is one of the ways that we look at this, it was a pretty representative sample from that point of view. This was not a population which was out of alignment with the level of burden that migraine exists in the population. So 41% of the respondents had 4 or more headache days per month, which is often seen as the cutoff or the point at which clinicians are strongly recommended to offer preventive medications for migraine. So we had a large number of people, a majority certainly, who had fewer than that number of headache days per month. So one of the things that was possible to do with this very large sample is ask about what the influence of stigma was at any given frequency of number of headache days per month, and look at it as a continuum. And overall, we found that the presence of stigma, often or very often, for either minimizing burden or secondary gain or both, was about a third of all people with migraine. So it was 31.7% of people with active migraine felt often or very often that stigma was present. And it very significantly changed with headache frequency, such that for people who had 0 to 3 headache days per month, it was about a quarter of people. And for people who had chronic migraine, that is 15 or more days with headaches per month, it was just under half, so 47.5%. So the magnitude of stigma increased significantly as the number of headache days increased. But even at low frequency of headache days per month, presence of stigma very significantly increased the likelihood of these other measures of migraine burden, such as your quality of life.
So what was the relationship between migraine-related stigma and disability?
Comparing people who had responded such that both secondary gain and minimizing burden stigma were present often or very often compared to people who never experienced stigma, the odds ratio of having high levels of migraine-related disability using the MIDAS tool to assess that, the odds ratio was 2.7. So nearly threefold increase in likelihood of having severe migraine-related disability just on the basis of the presence or absence of stigma, irrespective of how often headache occurred. And this rang true for all three of these patient-reported outcome measures, that is the disability MIDAS, interictal burden or MIBS tool, and the migraine-specific quality of life. And just looking at the migraine-specific quality of life, it's quite remarkable that for people who had 0 to 3 headache days per month and yet had the experience of stigma often or very often of either of these types, their quality of life was worse than people who had headaches every day and experienced no migraine-related stigma. So the quality of life was more influenced by the attitudes that people felt were being imposed by others about the fact that they had this disease than the number of headache days they had per month. And what this really says to us, I think, is that social context of this disease may be a greater impact, maybe of greater importance to the quality of life of people with the disease than the actual symptoms that we typically look at. And we insist on people recording that as number of headache days they have per month. And so we've been unaware. I mean, this is something that clinicians have been completely ignorant to, and understandably, because we have not had any measures to look at this. This is really, more than anything else possibly, the aspect of migraine which is significantly impacting their ability to live their lives fully and productively.
And what about interictal burden?
So interictal burden, the same type of relationship we found, which is that as increased number of headache days increased, the amount of stigma increased. But for any given number of headache days per month, the presence of stigma had a greater impact than anything else in terms of this interictal burden problem. And kind of what that tells you is that irrespective of when people may have symptoms which they recognize as migraine symptoms, obviously headache, sensitivity to their environment, nausea, aura, so forth, they may be intermittent. Migraine may be something which occurs in attacks that are discrete and they come and go, but the stigma may be imposed continuously. So there's no relief interictally from the stigma. It's there. People understand and appreciate, sometimes very directly, that they appreciate, that is, the way people talk about it. Sometimes they just are so concerned that this may be a detrimental aspect of how they're perceived that they hide migraine, that they don't tell coworkers that they're experiencing this, and impacts the quality of their productivity and their quality of life.
That's really tremendous. What do you think the implications are for clinical practice?
So this is really where the next types of studies really need to be directed. We have a tool now, and it's the first, I am sure, will be multiple tools to look at different aspects of stigma. But we have at least one tool which we can measure the impact of interventions to try to reduce stigma. And this is really not so much directly for the neurologist or headache specialist who is going to see their patient today, but rather how we start thinking about appropriately informative studies to try to reduce this problem. We need to get our arms really around the problem. What are the factors which have increased the likelihood of these malignant attitudes to be present? And we don't really understand them as well as we need to. Other early data that we reported last fall, again from the Overcome study, looking at a different set of questions for a panel of people from the study who did not have active migraine, asked about their attitudes towards migraine. And to our surprise and really somewhat to our chagrin, the respondents who were most likely to carry stigmatizing attitudes towards migraine were people who had the greatest degree of exposure to people who had migraine, that is, family members or coworkers or the like. So this is a particularly thorny problem because many of the interventions to try to mitigate stigma for other diseases which are stigmatized, whether it's mental health disorders or so on, have found that contact between people who have a stigmatized disorder and people who carry stigmatizing attitudes towards the disorder may reduce that stigma. But we don't really see necessarily that will be the clear pathway to help with migraine-related stigma. And that same study that I'm referring to that we reported last October looked at people who did not have active migraine. So these are people who may have in the past had migraine, but over the previous year did not have a history of any severe headache or migraine. And those people who had previously had migraine but did not have active migraine, they carried more stigmatizing attitudes than people who didn't have migraine at all, which also says that we have a tremendous amount of work to try to understand this. And I think it's premature to say what is going to be the best way to try to mitigate and intervene. But I'm confident that with a sufficient amount of resources to devote to this, to try to understand it, we'll make progress. I should also note that there are studies, and I would say Rachel Best from Michigan has published quite a remarkable paper that compares stigmatizing language in publications over a long period of time for about 90 different medical conditions to try to map together what the magnitude of stigma is for one disease versus another. And among all the neurological diseases, there's absolutely no doubt in her study that migraine is far more stigmatized than any other. And it's up there in terms of magnitude with the most stigmatized disorders. So mental health disorders are notoriously highly stigmatized, but it was kind of shocking to me that migraine is about as stigmatized as gonorrhea. It's completely mysterious to me why it should have this level of magnitude of being a problem. But it helps to clarify, why our results for this Overcome study have proven to be so dramatic. It's a big deal. This stigma issue is a huge part of the lives of people who are living with migraine, and we're just scratching the surface and trying to understand it.
I think when we think of pain disorders and migraine in particular as a biopsychosocial model, this is just really goes to prove that point, the impact of all of these components in the course of disease.
Yeah, I think we as clinicians, as neurologists, we don't get training to really think about biopsychosocial context of disease. And if we do, it's never really put at the forefront and really thought about as a huge driver of what leads to changes in quality of life. And I think that needs to change. It's not just for migraine, but just in general, we need to incorporate more understanding about these dynamics, which really make a difference. I think a part of it, that this is a separate study that I was a co-investigator with Phil Zhang and Kendo, which was reported recently, looking at how the word headache is used in common language. So this was looking at over 1 million major media publications over a prolonged period of time, asking how often the word headache was used as a medical condition, as we're talking about it now, versus as a metaphor of inconsequence, so like a traffic headache or something like that. And what we found was about half of the uses of the word headache in major media were disparaging. They were diminishing the impact or importance of headache as a medical condition. And since our understanding of words, the meaning of words, is based upon how we learn they're used, if you grow up learning that headache is inconsequential in at least half of the times you hear it, it is a very short step to concluding, therefore, head pain is not consequential, or migraine, which is so strongly associated with headache, is not consequential either. And so I think that these attitudes are really strongly embedded culturally, that migraine is not really a disorder that needs to be taken seriously. And people living with migraine learn very early, if they are experiencing it from an early age, that hiding it is a necessary thing, because they'll receive no benefits from trying to have it be understood that they're living with it and trying to seek resources to reduce it. It's better to not acknowledge that it's really existing at all and trying to multitask having the disease and living.
It's really uncharted territory and apparently very clinically relevant. What is the next step for this work?
So we still have quite a bit of data that we haven't yet plumbed from the Overcome study. It's really an extraordinary study to have been involved in for the last few years. There are longitudinal pieces, so folks who were queried in initial baseline studies, and then a year later asked a similar set of questions to see how these stigmatizing factors influence the progression of disease and the like. And we're just in the process of getting those data analyzed and out, so that I'm confident will be available in the next few months to a year.
Well, great. Do publish that in Neurology, and I look forward to having you back.
Thanks so much, Tesha. It's really been a pleasure to be here. And, this is something that everybody in the Overcome study is very passionate about. And we were deeply surprised that it proved to be as important an effect as it's proven to be. I think there's a lot of work that collectively a lot of people need to apply to this. So thanks very much for having me.
Excellent. Thank you for listening to the Neurology Podcast. Be sure to check out the full paper published in Neurology.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.